It is my pleasure to introduce Dr. Zoobia Chaudhry, a good friend of mine for a long time since my days at Hopkins. She is an accomplished physician and educator who is currently an assistant professor of medicine at Johns Hopkins School of Medicine. She is also program director for the Obesity Medicine Fellowship at Johns Hopkins. And she plays in that case an important role in shaping the future of healthcare in obesity management. At Johns Hopkins, Dr. Chaudhry is part of Healthful Eating Activity and Weight Program in the Division of General Internal Medicine. She sees patients at Johns Hopkins ambulatory clinics where she provides compassionate and evidence-based care to individuals dealing with weight-related health challenges. Dr. Chaudhry earned her medical degree from Allama Iqbal Medical College in Lahore, Pakistan, and completed her internal medicine residency at University of Iowa. Since joining Johns Hopkins in 2011, she has further refined her skills in patient-centered counseling and motivational interviewing through advanced training with Johns Hopkins Patient Engagement Program. Her research focuses on preventing weight gain in high-risk populations, such as patients with type 2 diabetes and cancer survivors. She also explores the efficacy of commercial weight loss programs, contributing valuable insights into the management and prevention of obesity-related complications. Beyond her clinical and research contributions, Dr. Chaudhry is deeply involved in education. She co-directs the Obesity, Nutrition, and Behavior Change course for first-year medical students at Hopkins. And she is a committed mentor and faculty for internal medicine residents, preventive medicine residents, and obesity medicine fellows. We are honored to have her here to share her expertise and insight. Before I ask you to welcome her here, I want to talk about a couple of housekeeping items. You see these QR codes in front of you. This is for evaluation of the speaker. Then there is a CME code that will also be displayed at the end of presentation for you to claim CME. When you're claiming CME at that time, you cannot evaluate speaker. Those who are present here in person, they have these small silver-colored boxes in front of them. There is a red circle. When you want to ask a question, press it, hold it down, it will turn green, and then you can ask a question at that time. Those who are joining us virtually, you can ask questions using chat box there in Q&A area. Once again, it's an honor to welcome Dr. Zoobia Chaudhry here. Please join me in a warm welcome to her.
Thank you very much, Dr. Kim, for the kind introduction. I really appreciate it, and it's good to see you and the rest of your team I've been communicating with. So it's been my pleasure. So I think since the advent of GLP-1 agonists and the medications like it, there has been such an increased interest in obesity as a whole, and I think we have jumped on the opportunity to speak about it and discuss why it is important to treat obesity and manage it. And I think the first question that many, I'm asked, and it's at the back of the mind of a lot of people when I talk to the residents, when I talk to my co-preceptors or even basic scientists that I work with to develop obesity medicine curriculum for medical students, I think there is this tension that is obesity is a disease or a behavior abnormality. And this is an ongoing debate, and it shapes how we interact with our patients who have obesity. It shapes our management of their problems, and it shaped how we see it holistically. So I think, from my introduction, you probably guessed that I will be talking in favor, like I will trying to convince you that obesity is a disease, and why is that? I do not have any relevant financial disclosures. And today as I said, we'll discuss obesity as a disease, and then understand pathophysiology of it. And because I think if we understand that where science is today, then that will help us chart our path. How do we treat it, right? And a lot of questions down the road are answered about it. Can you guys see my screen okay? Was that from before? Yeah, I feel like it's okay. Okay, so I want to start it with a case that I see this patient for I think over 8-9 years now, and she is with me as a patient, and I started seeing her almost, I think she's in her 70s now, early 70s, that when she was a 62-year-old and her BMI was 41, right? So we take a pretty extensive weight history, and she was a pretty typical kind of weight trajectory. You see that she was 115 to 130 pounds most of her adult life, and then slowly by late 30s, her weight was around 200. She tried several things, like Weight Watchers meal replacement. She would lose weight, but she will gain it back. At the point when I saw her, she had hypertension, pre-diabetes. She actually fell a couple of times and sustained patellar injuries, and she had hypothyroidism, depression, and overactive. And these are her medications. But despite the fact that she was on medication, wasn't controlled, and her weight was 250 pounds. So if you can, these are the things, right? So these are the things that kind of highlight what is in the weight loss trajectory, right? Patients we see, they try, they lose weight, but they regain at weight. And I'll address that. Why does that happen? And what is our perception about it? Right? Why does that happen? And then this is, and then, the medications you see that, slowly we are treating these conditions that, what if we treat these conditions and then, there is one disease that will impact, most, if not all, most of these conditions. And this has been her weight trajectory since till last December. When she started, she had BMI of 41, as I said, and a weight of 258. We started with lifestyle intervention, and I'll go over that, what that means, counseling patients to track what they're eating, managing, their, what they eat, how much they eat, physical activity, and using behavioral interventions to that. With that, she lost around 5% of her weight, which is around like, at that time was like 5-6 pounds, right? Then we started her on a meal replacement plan, and meal replacement plan in our clinic, obviously we have them take some protein shakes or other replacement throughout the day, and then they can have dinner on their own. And then along with that, because it kind of reduces their calorie intake to 1,200 to 1,500 to sustain that, I started her on phentermine along with that. Then along the way, she didn't feel it was working too well, the combination, so we added topiramate, right? And then at this point, after 1 year, she lost around 11%, and her BMI kind of got under 40, which means that she didn't have class 3 obesity anymore, right? She felt better. She was able to walk better. She underwent some knee surgeries, and that actually helped. And then at that point, obviously, she wanted to lose more weight. And then did not wanted to go for bariatric surgery. So I referred her. She went and spoke with different surgeons, and then she decided to undergo endoscopic sleeve gastroplasty, which is an endoscopic procedure where they go in and they stick the stomach into the stitches in the stomach, right? With that, she lost another 40 plus pounds, yeah. And then at that time, she's not on her blood pressure medications at this time. And then, she stayed there after a while that she gained a little bit of weight back after she was started on gabapentin for neck osteoarthritis. And then in the last few months, I've restarted phentermine at a lower dose, because at this point we stopped it because it was causing constipation, worsening constipation, and causing some sleep problems, even she was taking it earlier in the morning, and now she's pretty stable. She takes it twice a day, and then at this point, she is down 84 pounds, 33% of her initial body weight, and she's off of her pre-diabetes has resolved, and she's off of her antihypertensive and actually off of her antidepressants also. So this is what I'm trying to talk, like what what I want you to get out of my conversation today is requires modular treatment, multifaceted treatment for patients to lose weight, right? By looking at social media, you may feel like, patients, everybody in Ozempic is losing 100 pounds. And I could not. At this point, I did try to start her on Ozempic, but we kind of backed off because her reflux kind of was a little bit worse after she had the endoscopic sleeve gastroplasty. So, we avoided that. But that's not the case that everybody, so it takes time. It takes, it took her like 6 years or so to get to this point, and we did try different treatment modalities to get her here, right? But the question remains why there is low adoption of anti-obesity medications. And yes, this is changing now, but how much? I think I haven't seen any new data. I've seen some in primary care practice that there is some uptake. This is from 2016, right? So what they did is they compared use of anti-obesity medications to a newly, like at that time, SGLT2 came into the market. And this graph from the study shows that the prevalence of obesity is 46% in US adult population and 8.4% for diabetes, right? So when the new drug came in, it kind of like 86% of the physician were prescribing it, while for obesity there's 2%. And it's kind of goes back to the initial, what I said initially in the beginning of my presentation, that, why is that? And how do we understand obesity has a lot to do with that, right? So these barriers can be explained by the perception that obesity is not a disease, fear of causing dangerous side effects. And yes, there have been drugs that treated obesity had side effects like fen-phen. But I think if we do comparative analysis to other drugs, I don't think it's something that, obviously we try different things and, sometimes we fail in, executing that in public, right? So there are things that we have not foreseen and then we see them later on, right? And then the perception that the A1s are not effective. And then part of it kind of comes out. I'm asked this question at least once a week, not by my patients, but by other doctors, by other relatives or something. Like, okay, if I start this medication, how long? Okay, let me try this. Just give me a second. I'm getting some instructions on how to. Oh, okay. Now I see what was the problem. Okay, it's better. Yeah. So. Is it fixed now? Can somebody tell me in the chat? Yep, thank you. Okay. So so perception that it's not effective, and the way we kind of see, okay, what if I have to take it for a lifetime, then the medications must not be effective, right? So then that is something I will have to, if I have to take it for long term, and many patients don't like that, and I understand that part. But then again, that's part of the barrier I'm trying to help you overcome. Why do we think about that, and why is that, right? And then there is a challenge of cost and scalability, that if we have so many patients, how we are going to treat so many. So for any condition to be disease, there, like we classify it, science is all about classification. How do we get to a point? And there is like a lot of philosophical kind of conversation. Why is obesity a disease, or why we call some condition a disease, and why don't we, like when it's a normal variation, right? So here, like, is a framework that we use in other diseases, right? So what obesity is, and I'm going to talk about the two characteristics and harm and morbidity first, and then I'll come back to the pathophysiology. So obesity is a very physically visible disease, and that's, I think, part of how we perceive it as well, right? But if we talk about it, what are the characteristic signs and symptoms? It is increased adiposity, right? Increased collection of fat in different parts of the body. And but then there is, okay, then the next step comes in. How do we how do we assess that fatness, right? How do we assess that adiposity? That where do we, so, and we have this crude marker of BMI, which is an epidemiological tool, but then we use it clinically also, right? So again, I don't have time to go into this, but conversation here, but that is, I think, yes, but the disease itself has signs of symptoms, and we're still deciding how to gauge, right, that who has the disease and who does not have the disease. So that is where the controversy is. It doesn't mean that, it's, if we don't know how to gauge it, then it's not a disease, right? Then we have clinical staging tools from the AOSS. This was developed in Canada. And then we have BIA and DEXA scans, which actually DEXA scans are mostly used in research study where we kind of estimate how much is the body fatness, right? Then it does cause morbidity and mortality, right? There is a 15 to 20% increased risk of lost years. I meant this is 16 to 20 years of lost years, somebody with obesity as compared to somebody who does not. And then what happens is that the fat that is deposited or stored, it actually became pathological. It releases these interleukins that causes all sorts of other disease, the type 2 diabetes, mellitus, cardiovascular disease, and there's up to 20 cancers that are identified that are related to obesity or causative. The obesity is known to cause them independent of diet, right? And then there are physical disabilities, right? And there is osteoarthritis, right? Joint pain, patients, incontinence, all of those are also part of consequences of obesity. Now, circling back to why does this happen? Like, how come people have been becoming more obese? So the proposed mechanisms, and we know this more and more as with passing years, mostly from the patients who have gone bariatric surgery, from animal studies that we have found that there is appetite dysregulation, there is a normal energy balance, and there is endocrine dysfunction. And that is what I'm going to spend a little bit, because I know you guys know the characteristics and harm and morbidity, but I will talk further about the impairment, the pathophysiology, because I think that is mostly unaddressed in most of our learning. So what we usually think and how we counsel our patients that, okay, you have to eat less and move more, right? So what we are actually asking them that reduce your intake and burn more, right? But then we now know that it is not, there is a more to this story than just having that kind of like in and out, right? Plus minus conversation that we have, right? So I'll take you back to physiology. And I know in our medical school, they don't teach it. So I'm not sure in your medical school if they actually teach it. But there is, so how is appetite regulated? And right, so you guys came to the noon conference, it's time, so you feel like, okay, I should eat. So you went to the table where all the food was, and so that is how our body ghrelin is produced from the stomach and the gut, and then it tells our hypothalamus that, okay, it's time to eat food, and then you go seek out food, right? But then after you are done eating to a certain point, you start getting the signals that promote satiety, and then actually you see there's one that stimulate appetite, and there's like far more that promote satiety, right? So the short-term GLP-1, PPY, CCK, they actually send signal to the brain that, okay, we are full. And then for the long-term storage, if the body storage, the fat storage is regulated by insulin and leptin, that it tells the brain that I have enough fat like stored, I don't need more, right? So it seems like it's a pretty tight kind of mechanism. And then there is a reward mechanism, right? So you feel full, you feel satisfied. That's also part of it. So one may ask that if it is such a tight regulated then why is not body is keeping itself lean, right? So something has perturbed this symptom, this system, right? That and then most of it, the science kind of tells us that it's mostly like our environment, how it has interacted with our gene, and then it has created an inflammatory kind of situation in hypothalamus, or there's a neuron injury, or in the glial cells. There are different models that kind of like how exactly our environment has impacted and how exactly it has shifted this kind of appetite regulation. We go as we age, we go through different changes where these set points are also kind of dysregulated a little bit, right? And then another example is, we know this from, I think there's a study from 1994, that patients with obesity, they feel the reward sensation later on as compared to their lean comparatives, right? So that is there too, right? So there are more mechanisms that involved that has pushed this kind of whole regulatory mechanism to a higher point, where patients want to they need to eat more to feel satisfied. They need to eat more to feel full, right? And as we have learned more and more about these hormones, a lot of these things are not in the conscious control, right? And then another thing, other than the food and our environment, I think, is the medications. There is a lot of medications that we prescribe actually cause, and this is a very busy table, and you can find this table. We published a review in Annals in 2022, so it's part of that kind of review as well. So you can find it there. So again, going back to, there are medications that actually increase appetite, they reduce energy expenditure, and then we all know about prednisone, but there are like patients who take antihistamine, right? I have so many patients who are working 2 shifts, and then when they come home, and they just can't go to sleep in the morning or even at night, right? So then they're popping Benadryl to help them fall asleep. So again, it's not like if we remove these, this is going to solve our problems, but these are some of the factors, right? So antipsychotic medications are a huge factor in that. And again, a patient who is on, for example, Abilify or another, antipsychotic, and if we just tell them, okay, eat less, right? But we know that these medications actually increase patients' right. Similarly, Paxil is well known, and paroxetine is well known for that as well, right? So these increase appetite, these increase patients' food cravings. So just by sheer power of will, patient is not able to fight that, right? So that was like a little tangent that I want to go in, like other than environment and our food environment, how these things are impacted. So patients are, and in addition to environmental factors, obviously the genes, there are more than, I think it's 120 loci that are identified that regulates, all of this energy homeostasis, right? So what patients are like, because one person, and as you know, one person, and this, when I talk to couples, like they're eating the same things, but one person is gaining more weight than the other, or one is losing more than the other, right? In siblings, we see these variations. So there are such variation in genetic factors that how our body regulates, right? And then definitely there is a role of personal choices, right? So let me give you an example of hypertension. Patients, obviously, we know that the salt intake needs to be adjusted or regulated, or they need to change their lifestyle to have foods with less salt, and to manage their blood pressure. It actually brings down blood pressure by 10 to 11 millimeters of mercury, right? But do we sit in our office and we say, okay, unless you're going to change your lifestyle, I'm not going to give you an antihypertensive, right? So we don't do that. we say, okay, change your lifestyle. And so we don't want to hold the treatment hostage unless patients are changing. And that's I think is not ethical to do anyways. So yeah, so in addition to environmental factors and polygenic, there are so many other factors. And I'm not going to go through this whole figure, but I just wanted to give you an idea that there are so many social determinants of health that kind of go into that. What kind of a society influences food production, food consumption, like if there is activity, environment or not, right? So I've been to Richmond. I've not been to your area, but people who know Richmond, people who know Baltimore downtown, I have so many patients from there, and they cannot just get out and walk, right? Because the sidewalks are not that safe. So again, these are all the factors that are contributing towards obesity. So that was one side of the equation, right? That how much is that, how much do we take as energy intake? What are the factors that impact our appetite and, our food intake, and how it is processed and perceived and regulated by our brain? And then this is the other side of the equation, right? So how are we burning, right? So, and how that changes, right? So there are like different reasons or different things that we use this energy for, right? So we have to digest food, we do some physical activity, and then there is, just the resting energy expenditure, right? And you can see here that the part of the physical activity is small, and it kind of remains consistent between lean and obese individuals. And then as patients lose weight, this resting energy expenditure that in like normal kind of verbiage it's used as normal conversations, in layman conversation it's used as like my metabolism is kind of tanking. So yes, so once people lose weight, that actually goes down, right? So this graph here shows us that when patients actually when patients actually lose weight, their energy expenditure actually goes down. Why is that? Because more energy is required to maintain a larger body mass as compared to a lower, right? So the energy expenditure is going down, right? And then the second thing we see that when patients lose weight, they actually start when the patient starts to lose weight, they actually slowly gain the weight back, right? So here in this is the body weight, and this is the energy intake, so how much they're eating, right? So initially they were like around 2,700 calories, and they reduced their energy intake by 700 or 600 calories, right? But then what they noticed over time, their energy intake is increasing, right? Their energy intake is, and then you see how their energy expenditure is the same, right? So at this point, what we assume that they're not being adherent to their diet, and that's why their energy expenditure their intake is increasing and their weight is going up, right? So they're eating or they're gaining weight. That's the bottom line, right? So that's what we think. But actually, this is a very neat study from NIH which showed that their appetite actually increases. So every kilo of weight loss, their appetite went up by 100 calories, right? So they needed to eat more to feel satiated. So then the nutrition would tell you that I did not change anything, right? But then I'm still gaining weight, right? So in their mind, they are not changing anything, but actually their appetite is going, and they don't have control over that. So that's as a result of after weight loss, what happens, right? So there is adaptation with weight loss, and then there is also increase in the hormones that increase appetite, stimulate appetite, and then the hormones that reduce increase satiety, right? So those hormones are reduced here. So these are the things that the patient have to face if they lose weight, and that is why you'll see most of the patients who lose weight within a year or 2 years, they regain the weight, right? And in clinical trials, we usually see the lifestyle weight change with lifestyle actually 20% of the, so out of all the 20% are able to sustain that, but 80% of the patients regain that weight, right? So that's a huge population, and that's like our cutoffs for being clinically significant weight loss is 5%, right? So that is what we are talking about, that how many patients are 5 to 10%. So in a 200-pound patients, that's 10 to 20 pounds, right? And we know a lot of our patients need to lose more weight than that. So these are on the, so there is the body undergoes adaptation with weight loss. It actually tries to push the weight back up, and none of this is in patient's control, right? So all of this information helped us redefine obesity as a prevalent, complex, progressive, and relapsing chronic disease characterized by abnormal excessive fat or adiposity that impairs health, right? So if we kind of follow this kind of path, then we will see why that how our approach towards obesity should change, right? So the tiered obesity management includes lifestyle intervention with nutrition, physical activity, behavior change. That everybody who's in overweight range will get that counseling or intervention. And these cutoffs are for Caucasian population and African American population, but for Asian population, you can reduce it by 2 points. And then the next step is anti-obesity medications. So anybody who has BMI of 27 with risk factors of BMI of 30, so you not only do lifestyle intervention, but you also do anti-obesity medications. And again, it's really is how you approach it. I personally do not withhold treatment with anti-obesity medications unless they change their lifestyle. Definitely, we counsel them with it. And then the studies actually shows that the anti-obesity medication helps them adhere to a better lifestyle, right? Because it is easier for them, right? So if somebody is on so an average, when I have my patients track, they're consuming between 3,000 to 3,500 calories, right? So to lose weight, we are asking them to be between 1,200 and 1,800 calories. So we're asking them to cutting less than half, like more than half of what they're at that point. And obviously, it doesn't have to happen in 1 month. But then if there are medications that help them stay and they're not like miserable doing that, then it improves their adaptation to the healthier lifestyle. And then there are endobariatric and metabolic bariatric surgery. That is at BMI of 30 and or with risk factors of 35. And these numbers have kind of been revised as of last year. It used to be 40 and 35 that way. But then recently, Bariatric Society has updated these numbers, right? So let's go a little bit more into this kind of like lifestyle intervention. What does that entail briefly? So counseling strategies, and again, this is, I think, is the key. If our clinic is not able to offer this, that patients do need regular interaction, whether it's individual or group, at least we ought to know that this is what it takes for them to be successful in implementing a lifestyle intervention, right? So if we see them and we tell them that, okay, I'll see you back in 6 months or I'll see you back in a year, and we say, okay, you need to lose weight. Yeah, so that's not going to work, right? It may work for a handful of patients, but that's generally, it doesn't work. And then, so identifying resources within your community where such group sessions are held, or, if there is an obesity medicine provider or any other provider who's doing that. So I think the key point is understanding what it takes for our patients to be successful. And then in nutrition, there's so much conversation about how patients, what they should do, like the whole, keto diet and the low carb and high protein and you name it. There's so many, intermittent fasting, all of that, right? So, but the take-home point is the quality and quantity both matter. Improving the quality of food while reducing the quantity, right? So quality, we improve the quality by increasing the whole foods, limiting ultra-processed food, limiting added sugar, salt, saturated fat, and alcohol, right? So those things, if we limit, that would improve the quality and also will reduce the quantity, right, of what they're eating, right? And the factor that we see again and again, patients who have been successful with dietary changes, is that if they can adhere to it, right? So if you can't adhere, if it's a novel kind of thing in your life that doesn't go with your lifestyle, if you can't find time to stick to it and to cook all of that, or if you're just miserable, hungry on it because it is so far restrictive, then you're not going to be able to adhere to it. So what we ask our patients to we ask our patients to bring us what they eat, like so by tracking or by taking pictures or like whatever means they find convenient, and then we help them make changes within their within their framework of their lifestyle, right? So again, they have to live their lives. It's not like they can leave all of their responsibilities of cooking for kids or family aside and then just do this, right? So we have to work with them. And then you can definitely ask for dietitians in your community if they are able to counsel patients on that. But just imparting information on patients is not enough. We need, counseling how to do that, right? So not only what they need to do, how they need to know how, right? And then physical activity. This is so many times I hear from my students, right? So yeah, I saw this patient and I advised him to do more physical activity. And again, I tell them this, and I'll tell you this: if you're going to forget everything from this conversation, try to remember this one thing, right? Exercise should not be the sole weight loss strategy, right? It does not. It probably between have to kind of 2 kgs in a year if somebody's doing, moderate to intense physical activity. So exercise has so many benefits. It preserves lean mass. It helps with weight loss maintenance. So we definitely work with that. But then definitely it has a lot of cardiovascular and all other benefits. But then understand when you're asking patients to do that, what is it that they're getting out of it, right? So it's critical for weight loss maintenance, but doesn't have a huge role in weight loss. It doesn't mean that we should not, talk about it, but definitely, and what are we getting out of that advice we need to understand. Okay. So now, obesity. So we did the lifestyle intervention. Then the next step is anti-obesity medications. There are 6 that are approved by FDA at this time. I'm not going to mention one, which is kind of for like the genetic monogenic obesity, because that's very rare. But then if we divide them by 3 categories, so one is centrally acting. So these all reduce the appetite, and you can see the mechanism underneath it. So phentermine, topiramate in the combination, it comes as glycemia, and naltrexone, bupropion as contrave, right? So they all stimulate these hormones, these receptors in hypothalamus and regulate appetite. And then there is gastrointestinal medication, orlistat. This is one of the oldest medication, and it blocks the digestion and absorption of dietary fat up to 30%. And then the newer class, which are called the nutrient-stimulated hormone-based medications, where it impacts the brain and gut axis, right? And that is why it kind of impacts 2 sides. So that's why we see they are definitely far more effective than the drugs we had before. But then in addition to these medications, we have off-label. There's long-term off-label use of phentermine. Phentermine constitutes about 94% of all anti-obesity medication prescriptions. So it's very common. It's been around since 1960s, 50s, 60s, and it is approved by FDA for 3 months because those were the trials that were done at the time. But then since then, the American Endocrine Society says that we can increase we can use it for long term as long as certain conditions are met, right? But so that a decision that a physician who really feels comfortable can make with the consent of their patients. And then there are other medications that and that are there. Then if we have issues with coverage or side effects, and then there are some choices. And then comes the bariatric surgery, that produces up to 60 pounds of weight loss, 80 pounds of weight loss. So those are the few. And then endoscopic sleeve gastroplasty that my patient had, up to 15 to 14. And then this weight loss is sustainable, right? And then a lot of data that we have on GLP-1s and GIPs is coming from these studies, right? So how the hormone regulation actually changed and helped patients to maintain, not only lose but maintain. And thus, initially it was thought it was all restrictive because we have made the stomach small, so they did the bariatric surgery. But now you'll see in the literature name metabolic and bariatric surgery, because we see a lot of these hormonal changes with the bariatric surgery too, right? So then question becomes like, how do I pick what do my patient need, right? So I think first identifying how far do you want to go with the weight loss, right? So keep pressing. On average, people lose around 3 to 10% weight loss with lifestyle intervention. So if somebody needs to lose 100 pounds, and if you just keep pressing lifestyle intervention, that's just probably not going to take them far, and it just causes frustration, and also on side of patients as well as on physicians, because physicians feel like that the patients are not doing enough, and the patient feel like that they have let themselves and their physicians down, right? And then similarly, the weight ranges for the other, right? But and also to see what benefit we want out of. So it's not just number on the scale, but like how much weight loss would produce what benefit, right? A lot of patients want to get off the medications there are, and they also think that they need to lose a ton of weight, right? So all pun intended, that they don't need to lose 40 plus pounds for everything. If they lose 5 to 10%, a lot of these changes, a lot of their comorbidities would be improved. So I think identifying how much weight and what do we really want out of that weight loss helps us identifying the goal for our patients, and then working towards that goals. But it does happen once patients is successful. By 10%, they would want to lose more weight. But that's a separate conversation. And I think we have to discuss with our patients, what do we really want out of weight loss? What do they think will happen? I always ask my patients, okay, well, what is your goal? Then they say, I want to lose 100 pounds. And then they say, okay, if I said, like, what will happen what do you think will happen if you lose 100 pounds? And I will say, or you go back to your high school weight. Well, I want to get off those medications. And I say, okay, well, you don't have to lose that much weight. If you want to lose, like, get rid of some of these medications, then, let's start with 10%, right? And that seems like an achievable goal for them. And then we can select appropriate treatment for that, right? I would just go in a little bit detail about the new medications, and because they have generated so much interest. So just briefly about them. Semaglutide, here is the dosing schedule for it, and you can see. So this is a little bit different than Ozempic schedule, right? So the brand for the weight management is semaglutide. So this was the clinical trial that was done in patients with obesity. They did not have diabetes, and then they lost 12.4% of their initial body weight, right? So on average, that's around 34 to 35 pounds, and it was effective in far more patients, right? So more than 77% of the patients lost more than 5%. So as you see, for clinical studies and for clinical management, 5% cutoff, we consider that significant, right? There's a lot of comorbidities improved with that. So then the other drugs that I shown you before, the centrally acting, is, if we look at their efficacy, they usually are producing up to 8 to 9% or 6 to 8% weight loss, and then they are effective in 50 to 60% of the patients, right? Patient population. So not only it is causing more weight loss, it works in more patients, right? And then that is not only it. I think this was the first time that we, with the drug, we have shown that the risk of cardiovascular disease is cut by 20%. So we've seen this in patients who have like diabetes with these drugs, but just these are the patients with obesity without diabetes, that the risk of cardiovascular event is reduced in patients who have pre-existing CVD, right? So now I think recently in Maryland, they have started to allow patients with obesity um, and obesity and cardiovascular disease, and they gave us a criteria that they will cover these medications, right? And then it also improved the heart failure symptoms in patients with symptomatic HFpEF. So these are the other, and this is not only, and as if you look in detail of these studies, then and then the scientists think that there is evidence to prove that this benefit is beyond weight loss. So there are hemodynamic changes with these drugs that actually are responsible for these cardiovascular benefits, right? Then comes tirzepatide, comes as Manjaro for patients with diabetes, and comes as Zepbound, right? The titration schedule is the same. And then in this study that the patients lost close to 22%. What does that mean? An average patient lost 52 pounds. So this now, with lifestyle intervention, all of this, we are getting close to like bariatric surgery weight loss. And this is not it. We have so many new drugs that are in the pipeline, including oral semaglutide, and then once a week or once a month injections, right? And then some of those are like actually improve the muscle mass. So patients, who have advanced stage and have like muscle loss already. So that is what we are looking at in the future. So this is not where we're stopping. There's so many more drugs that you would see. And if you have, if you've been following what I've been saying for the last like 30, 40 minutes, as we stop these medications, the weight regain occurs, right? And this is one of the studies to show it didn't go all the way up, but this is like 5.8% below their baseline, and this is on the maximum dose of semaglutide, right? So that is so. But then the weight regain, and you can imagine when those receptors are not blocked anymore, it is just evident that and that's with all anti-obesity medication. Once we stop it, the weight will come back, right? So we monitor for the side effects. We manage side effects. A lot of patients do feel nausea, vomiting, more nausea, reflux with these. So I think counseling patients to change their lifestyle along with this is helpful in managing side effects. So I counsel my patient to reduce their portion sizes, because if they are used to eating a certain amount, they're gonna feel too full, right? They're gonna feel too full to if they are on the medication and they're eating the same way. Managing their other comorbidities, I typically reduce their insulin. If they are on an insulin or sulfonylurea, I just stop sulfonylurea, because hypoglycemia could be severe if they are on those drugs, along with newer GLP-1s, right? So monitoring their side effects, efficacy, slowly titrating the drugs up. We don't have to hit a number, like we have to get to the maximum dose. I just keep them at the dose where it is effective, unless insurance pushes them to go up, right? And then the side effects, obviously, there are like none of our interventions we do have like no side effects. Anything we do comes with its side effects. Most of the thyroid cancer, medullary thyroid cancer, this is from rodent studies. So none of the human studies so far has shown any increased risk of cancer, right? And we have GLP-1s for like almost 15 years now in the market for diabetes, so we have that data from it, right? But making sure that we're cautious and avoid in patients who have pancreatitis and actually have like very heavy alcohol intake, we don't give it to them. And then obviously there has recently been some FDA has changed their, the guidelines to make sure we screen for depression or suicide. So there's like no noted increased incidence of suicide in these patients, but then nonetheless there were some reports in the media, so that was added. So those are like the general side effects of all of the anti-obesity medications. And then obviously there are issues with insurance coverage and supply chain issues that we keep often on combating with these. And if you are part of this, then you would know how difficult it can be. And that is why I think it's also important to learn about other anti-obesity medications, and as the coverage and the availability of these newer drugs has improved, right? So in the end, I'll just conclude that in by 2030, like in 6 short years, 5 short years, 50% of US population will have obesity. So no matter what subspecialty or even prime, like wherever you are in your clinical practice, once you graduate, or like you will have, every other patient will have either, you will be managing their complications from obesity or obesity itself, right? So it's not going to be just the job of the obesity medicine subspecialist. We all have to deal with it, right? So I think the first step is to recognizing that and then seeing what we can do about it. We have these modules and many programs across the nation, kind of peak modules. They see those and they go to the content on these modules, and then you can also consider obesity medicine fellowship. You can visit obesity medicine fellowship site that is mentioned here, and then as Dr. Kiyum mentioned initially, I direct the fellowship program at our university. So, and then we have resident electives. So, finding somebody in your community who does that, and then trying to learn more and build your self-efficacy and to manage patients with obesity is something I personally feel is worth investing into. So this is our multidisciplinary team. We're not all under one roof, but this is what I was explaining to somebody else yesterday, that you have to identify people within your community that kind of like understand obesity as a disease and work with you in managing your patients, right? So some of them are work with us, and some, so this is our core team, including our fellows, and then we have a team of subspecialists who do that. And that is all I have for today. I hope we have time for question and answers.
Thank you. Thank you very much. That's a great talk. Questions? Go ahead, Dr. Chaudhry.
Hi, thank you for your talk. Are you seeing an influx of patients who would be more appropriate for bariatric surgery out the gate, especially since the indications for surgery have broadened? Since the microvascular complications are more quickly halted with surgery, is there a type of patient, like say a 40-year-old who has a BMI of 38, already has diabetes and hypertension, already demonstrated they failed, the normal diets? Is that the type of patient where you would advise the PCPs who are dealing with, the media frenzy of all these weight loss drugs to make sure they're also concomitantly talking or referring for bariatric consultation?
Yeah, definitely. And I do that when I teach, like when I precept my internal medicine residents. And yeah, so again, as I said, it's a stepwise treatment, and then you have to pick a treatment from what is available, right? So it's just like, if they have failed, lifestyle intervention, and or they have lost some weight with lifestyle intervention, but they still haven't met their goal. So then we escalate the treatment. To your initial part of your question, have I seen an increase? No, I have not. Actually, I have seen more, and then again, it also patient has to agree, right? So, I have seen definitely surge in patients asking for the newer drugs more, but I haven't seen more requests to go to bariatric surgery. But what we teach and what we counsel our patients is that all of these are viable options and should be used in combination to manage.
Dr. Tahan.
Thank you for a great talk. Once you have patients on GLP-1 analogs, the question that comes up, do they go off of it? Do they remain on it? And what has been your experience in terms of if they get off of it, do they gain the weight back? Should they remain on it? And do side effects compound the longer they're on it?
That's a great question, and I think that is something patient and the physician has to discuss. I have I have now rarely patient who wants to go off of it, right? Because they've seen how it changes their relationship with food. What I think the few things that we have tried and you can find in different reviews and literatures, and this is all like kind of expert recommendations. One, like not everybody needs to be on the full dose. So, for example, if they lost X amount of weight and then now in the weight loss maintenance phase, then they don't need to be on a maximum dose. So, can we maintain them at a lower dose? So that is one option. The other option is that can we maintain them on oral alternatives, right? So is it going to be as effective or not? And it is such a polygenic disease. I have seen such a variable response that some people may be able to maintain their weight on it, and some people may not, right? So I have a patient who is on oral semaglutide in her weight loss maintenance phase, and then she's doing okay with that, right? But then the others, they may regain all the weight and then some more. I think there is also subjective feeling, which we have discussed among ourselves as obesity physicians, that some of them just feel like that their hunger is worse when they are off of it. And we don't have any data to support that. But then we know that, and I think with weight loss, definitely we know that their hunger goes up, but there may be some subjectivity to it that, they stopped feeling that hunger and then now it just feels even worse when they're off of these medications. So yeah, so all options are on the table. These drugs are definitely approved for long-term use, but then we can maintain them in a lower dose or an alternative once they lose weight. Yeah.
Dr. King?
Thank you. I've had to use a little more phentermine just because I can't get my GLP-1s either approved or they've been approved for a while and now insurance won't cover it anymore. I've been very hesitant to extend it past 12 weeks. I know you talked about that a little bit and you said some patients you can continue long term. I'm just curious, are these just patients that aren't having side effects from it that you continue it, or are there other things you're looking for?
So there are other things that we are looking for, and if you, so I can email the slides and the reference should be on that. But if you Google like 216 endocrine pharmacology treatment for obesity, then you can find that. And I have a little dot phrase for my notes that phentermine can be used for long term if you and I as a patient agree that. There is no risk you don't have a risk of cardiovascular disease, right? So you don't have existing cardiovascular disease, you don't have ongoing depression or uncontrolled hypertension, right? So there is a data from Kaiser that came out, I think a few years ago, I think maybe 3-4 years ago, that showed that the patients have been on these medications for 3 years plus, and it did not raise their risk, and this was more of a prospective trial. It did not increase the risk of any cardiovascular event or hypertension in them. So there's definitely data existing, and that is something. And then the fact that the glycemia, which is combination of phentermine and topiramate, is approved for long-term use. So I think combining all of that information, as obesity medicine experts, we feel pretty comfortable when we make sure we see these patients at least every 3 months to make sure their blood pressure is fine and they haven't developed any side effects from it.
Dr. Dixon?
Very wonderful talk. Thank you. Do you do anything with group visits for lifestyle changes where you bring dietitians and maybe psychologists who are focused in this area and exercise experts together and allow patients to access that as they need and in a group setting? Yeah,
so thank you for the question. It's a great. We actually, I was part of the team. We developed group sessions based on, there was a look ahead trial, DPP programs, probably it's a national program, DPP. It's limited to, they offer it to patients with the pre-diabetes. So that's a good resource for you can find it for your patients locally. But then, based on that, we have developed groups for patients with obesity, obviously with any kind of comorbidities. But to answer the second part of questions, it's all our physicians who are doing it, right? So one of our colleagues, so we developed the curriculum. It includes how to reduce, what you're eating, reducing calories, increasing physical activity. How do you manage stress? How do you manage your, hunger cues and sleep management? So all of that, right? So those are the groups that are one of the sessions is run by our fellow, and then two of our faculties actually run that. But what we have been, I think we are hoping to start that next month for our families, right? So this is under the pediatric obesity faculty that they have developed this program, and our faculty is part of that. Where what you're asking would be like that. We have dietitians, we have exercise physiologists, we have behavioral therapists, and they will combine, and the whole curriculum has been done, and then they will be conducting these sessions for parents and the kids. So we have kind of both. Mm-hmm.
Thank you very much.